That's why India single step method is the most effective method in most of the centers. These are better guidelines. 75 grams of glucose, oral glucose tolerance test. They are fasting more than 92 or more after 75 oral glucose taken after the 1 hour levels like more than 180 or 2 hours after more than 150. These are the insulin is the main primary treatment for the gestational diabetes. But initially, while diagnosis GDM, even how to follow up insulin also, like first we have to try medical nutrition therapy, then we are going to for pharmacological therapy. Not good control, even postpartum glucose after repeat checkup more than 120 is there, then we have to go for medication like that, like insulin or metformin therapy.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your liked videos so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
Today we are discussing with our GDM with latest trends in diagnosis and the treatment of management of diabetes, gestational diabetes mellitus. Uh, Pregnancy itself, it is a diabetogenic state. Generally, definition of GDM in diabetic in pregnancy, carbohydrate intolerance of variable severity with onset or first diagnosis during pregnancy. It generally occurs in second half of the pregnancy. This definition is undoubtedly includes some of the women with previously unrecognized over diabetes also. In diabetes, like previous, we are like it is a mainly diabetogenic state. No effects of like pregnancy in diabetes, like pregnancy alters carbohydrate metabolism like such way that more glucose available in fetus. In general pathophysiology, like that, pregnancy itself is a diabetes. In diabetes pregnancy, more towards like fat deposition occurs first and second after the trimesters, more towards the placenta. That's why in during pregnancy, while going on, like insulin resistance will gradually increases because of increased placental hormones such as like they're going to agonize the insulin sensitivity. That's why increases insulin resistance and decreases the insulin sensitivity, which is further aggravated by increases the body weight and calorie intake of during pregnancy. Mostly like human placental lactogen, also known as human chorionic somatotropin, mostly promote that it's a lipolysis, making free fatty acid available for uses of mother her own energy needs and available adequate glucose intake also. And gestational diabetes occurs when the pancreas, despite of the production of insulin, fail to overcome the effect of these contrast insulin hormones like human placental lactogen, estrogen, and progesterone, and cortisol and prolactin. These are hormones produced by placenta. That's why while most of the insulin resistance conditions, mostly we are noted in maximum in pregnancy, like 24 to 28 weeks of the gestation, like you will see there like maximum insulin resistance for pregnancy, insulin resistance available in pregnancy. Like we have to see like postprandial hyperglycemia because of insulin resistance, glucose diverted to fetus for feeding of mother, like whole and soul fetus for available energy from mother only. Even like uh, they are mostly like fasting hypoglycemic like status because of maternal pancreatic insulin. The levels are increases in pregnancy state. What are the risk factors in gestational diabetes is mainly age factors and history, like they are like more than age of 30 years or past history of gestational diabetes, family history of diabetes mellitus, and any bad obstetric history like stillbirth or recurrent fetal losses are present, and even prior history of previous history of macrosomic baby is there, and if previous fetal malformations and unexplained perinatal losses and history of any polycystic ovarian disease, these are the factors for well, history, they will give risk factors for gestational diabetes. And during pregnancy, they mostly like polyhydramnios, recurrent vaginal candidiasis, and recurrent urinary tract infections, and obesity, and any congenital fetal anomalies noted in antenatal scans, and any preeclampsias, and persistent glycosuria. These are the during pregnancy, they are more prone for gestational diabetes, GDM development of the pregnancy. And how to assessment in gestational diabetes mellitus, like lower risk are like age which less than 25 years or weight normal before pregnancy according to BMI, and no family history of diabetes in first degree relatives, and some of the ethnic groups with a low prevalence of GDM, and no bad obstetric history, and no history of any abnormal glucose metabolism. These are routine screening not recommended in low risk groups. And an average risk like that, women in Southeast Asian origin, including like Indians, and women of Native Americans and Africans. And these are the testing like generally like 24 to 28 weeks of gestation age. We recommended that gestational diabetes test one step or two step method. We have to recommend it for screening of the patients. High risk patients are severe obesity and positive family history of type 2 diabetes, siblings or parents, and history of diabetes in previous pregnancies and glycosuria. These are recommended for high risk gestational diabetes. They are as early as first antenatal visit only. We have to screening for the gestational diabetes and again repeat after even 24 to 28 weeks of gestational age. What is the main diagnostic methods for gestational diabetes, GDM diagnosis? Like GDM in India, mostly like single step method. These are government of India advises methods like adapted by DIPSI guidelines like that. Single step method mostly in India, they are follows most of the centers like that. Uh, Diabetes in pregnancy group of India, study group of India. These are recommended as adapted by government of India. In single step method, what is that? There is no need of any like fasting requirement, not require any fasting. Irrespective of the fasting, we have to going to do like 75 grams of glucose, oral glucose tolerance test in 75 grams of oral glucose mixed with 200 ml of water and consumed in 10 to 15 minutes. After that, we have to check 2 hours of the postprandial levels. More than 140, it is a gestational diabetes. If less than 140 is a showing of fasting, less than 92, we have to repeat after like that 24 to 28 weeks after uh, gestational. We have to repeat again these 75 grams of the oral glucose storage. These are most of the Indian, like first antenatal visit as early as they are coming to the hospital. First time also you have to do. These are single step method for uh, adapted by government of India, recommended by DIPSI guidelines. Because in our country, like most of the people, rural population, while coming to the hospitals are low, so long, they are waited for in OPs long standing. They are not to. You have to. They have to come tomorrow again. They're fasting. There are some difficulties. That's why India single step method is the most effective method in most of the centers. These are following. These are better guidelines for. We have to like diagnosis of GDM patients. Another method like that in a single step method advantage like the pregnant women need not do fasting, and even it causes least disturbance in pregnant women and routine activity. It serves both screening and diagnostic procedure. The pregnant woman may not turn up again if fast come to fasting the next day, because of these are coming from rural population. They have to again fasting come from their own places again doing a long lineup. They will not wait for fasting levels. This very cumbersome process. That's why single step method is a very most of the government hospitals and even government of India adapted these are DIPSI guidelines. In disadvantages like over diabetes, like difficulty in over diabetes. And another method like one step method only in WHO recommended, like these are adapted by International Association of Diabetes Pregnancy, a study group. Like in this one step method here, fasting required in WHO method screening. There are 75 grams of glucose, oral glucose tolerance test. They are fasting more than 92 or more after 75 oral glucose taken. After that 1 hour levels like more than 180, or 2 hours after more than 150. These are the GDM diagnosis of GDM. Like these are recommended by one step method, like in WHO method, like International Association of Diabetes and Pregnancy Study Group given guidelines that are adapted by WHO. In this, like WHO method 75 oral glucose, if fasting more than 126 or equal or more than in 2 hours of the postprandial more than 200, or random blood glucose levels more than 200 milligram per dl per plus symptoms are present. These are the over diabetes diagnosis condition. Like they are mostly diabetes present in pre-gestational age only. In this, like that, HbA1c also recommended if HbA1c more than 6.5 or even more than, these are the indicator of over diabetes conditions. And two-step method, like these are glucose 50 plasma glucose measured like 1 hour after 50 grams of glucose load without any regarding time of the day and last meal. They have generally less than 140. These are the non-diabetic condition. If more than 140 or more than 200, it is a over diabetes condition indicated. In person with after 50 gram glucose taken in two-step method glucose challenge test like 140 more than, and 2 hours after that more than 200 185. These are GDM patients with a two-step method where glucose tolerance is done in two-step method. In while once these are the guidelines like WHO and International Association of Diabetes Pregnancy Study Group and DIPSI guidelines. These are like in India, like mostly adapted like 75 grams of oral glucose tolerance. These are the adequate and easy feasible for without any fasting. And uh, first visit of any antenatal visit, they have to perform, not to wait for 24 to 28 weeks of gestational. Irrespective of the gestational age, you have to done first antenatal visit only. You have to done 75 oral glucose tolerance. You have to done in India. Like government of India adapted. These are the guidelines for GDM diagnosis in most of the uh, healthcare workers and primary healthcare centers and tertiary in government hospitals. They are following DIPSI guidelines only while given by DIPSI recommendations. What are the complications like diabetes in pregnancy, like effects in pregnancy and diabetes on pregnancy, maternal complication and fetal and neonatal complications. In effects on pregnancy and diabetes, these worsens of pre-gestational and over diabetes also. In even they are required diabetic diet also may going to require insulin therapy. Those on even oral hypoglycemic drugs also they have to change insulin levels. Those on insulin may also require higher dose of insulin because of insulin resistance increased by during pregnancy, while going on gestational increases, insulin dosage also increases. Pregnancy worsen even diabetic vasculopathy like nephropathy, retinopathy, and microangiopathy conditions, and even increase the risk of diabetic ketoacidosis in pregnancy. Even effects of even diabetes on pregnancy, like maternal complications, like poor glycemic control is the most important for maternal complications. Like pre-gestational diabetes associated with the higher rates of maternal complication than gestational diabetes. Like who are the over diabetic patients? Mostly they have like abortions and congenital anomalies of the babies will not noted in over diabetes patient compared to than gestational diabetes. And antenatal complications are infection like recurrent urinary tract infection and pyelonephritis and vulvovaginal candidiasis. And some of the patients like preeclampsia noted 25% of the patients, and polyhydramnios and preterm labor also. And during intrapartum, like prolonged labor or increased instrumental delivery and lower segmental cesarean section requirement of the patient, and perinatal trauma also occur. And some of the patient going to like postpartum hemorrhage also they have to going to develop. And postpartum, like delay in the wound healing and infections will develop, and pleural purpural sepsis will also occur in some of the patients will postpartum after delivery they have to see some of the infections. In uh, fetal and neonatal complications are maternal hypoglycemia is the most important cause for fetal and neonatal complications. Fetal complications are mostly like abortions in uh, and congenital malformations and macrosomia and some of the premature delivery, sudden intrauterine death. Also, some of the even 36 weeks of the intrauterine deaths of the babies, even still good glycemic control. Also, they have to develop intrauterine deaths of the babies will occur. And some of the birth injuries like shoulder dystocia during delivery times will occur because of macrosomic babies. They have to present like birth injuries will develop during delivery. Neonatal complications are like respiratory distress syndrome, hypoglycemia. There are babies like neonates hypothermia, some of the hypocalcemia also occurs, and hyperbilirubinemia and polycythemia and myocardial hypertrophy over the or diabetes also occur. And future risk, they are going to develop diabetes and obesity. Sorry. And these are macrosomic baby born with a gestational diabetes mellitus mother. During management, insulin is the main primary treatment for the gestational diabetes. But initially, while diagnosis GDM, even how to follow up insulin also, like first we have to try medical nutrition therapy, then we are going to for pharmacological therapy. Some strict management like antenatal, intrapartum, and postpartum, they are another variant of that we have to manage during intrapartum also, insulin control for appropriate delivery. These are required. In medical nutrition therapy, medical management like glycemic control with diet and exercise, and insulin therapy and oral antidiabetic drugs also tried for gestational diabetic patients. Uh, Patient with diagnosis with a gestational diabetes, first we have to start medical nutrition therapy for 2 weeks. If still after medical nutrition therapy also they are not good control, even postprandial glucose after repeat checkup more than 120 is there, then we have to go for medication like that, like insulin or metformin therapy. We have to start oral anti-diabetic drugs. Also, we have to start. If less than 120 postprandial glucose level, again repeat after 2 weeks in second trimester. We have to repeat the postprandial glucose. In third trimester, every week we have to repeat postprandial glucose levels because we have to check uh, strict glycemic control in even during medical nutrition therapy. If more than 120, we have to start insulin and also our oral anti-diabetic drugs in second. Oral anti-diabetic drugs mostly in like second and third trimesters are good for uh, management of the gestational diabetes mellitus. In diet therapy, like we have to medical nutrition therapy means in GDM means like uh, in pregnancy described as a carbohydrate controlled meal plan should be promoted in adequate nutrition with appropriate weight gain. You have to advise a normal glycemia and in absence of ketosis. Calories requirement like mostly like moderate calorie restriction like 1600 to 1800 kilocalorie per day. 33% of reduction does not lead to any diabetic ketoacidosis during pregnancy, reduces diabetic ketoacidosis rate. And daily energy intake also almost like 2500 kilocalories as per BMI all categories. Men with GDM as reported with reduced weight gain and maintain the euglycemia and some of the avoid ketonuria and achieve average birth weight of the babies in medical nutrition therapies. These are the calorie requirement for uh, gestational diabetic patient like underweight women like that 35 to 40 kilocalories kg per day. You have to daily requirement of the calories underweight women. And we have BMI normal weight women we are require normal weight women persons like 30 to 35 kilocalories per kg per day. We have to require uh, daily requirement of kilocalories according to calculate. And overweight women we have to require 25 to 30 kilocalories per kg per day. We have to require for nutrition kilocalories. Overweight women, obesity women. How to plan like medical nutrition therapy like carbohydrate restriction meal therapy. In this we have distributed carbohydrate like three meal like small to moderate size meals, three snacks to reduce the because postprandial glucose levels, these are GDM patient more level fluctuation will occur, and you have to carbohydrate intake limited to 30 to 45% of the total calories. In normal Indian normal meals, like normal persons, we have to without GDM or normal person generally we have like plate like 50 to 60% carbohydrates, 30 to 40 like fats, and 10 to 20 to 15% protein. But here we have to reduce the carbohydrate intake to 35 to 40% of total calories with a minimum of 175 grams of carbohydrates per day. We have to require in gestational diabetic patient. Determining the carbohydrates intake of meals and snacks is termed as carbohydrate counting. Carbohydrate counting, how to estimate means carbohydrate amount each meal determined by the carbohydrate serving. 1 gram of carbohydrate uh, these how to calculate like carbohydrate serving means like 15 grams of carbohydrate is equivalent to 1 carbohydrate serving. Generally, 1 gram of carbohydrate produces like 4 kilocalories of energy. We have to plan for 175 grams per day. Like the carbohydrates, they are counted like carbohydrate serving too. We have to plan for carbohydrate serving. We have to distribute like that three small meals, small to moderate sized meals, along with three snacks too. Because of we have to reduce postprandial glucose levels fluctuation in, because most of the persons like postprandial hyperglycemia will occur in persons with gestational diabetic patients. And dietary fibers also we have to like restriction of saturated fats like less than 10% and increase intake of dietary fibers they are advised. And fiber intake particularly like the soluble fibers, because these are helpful in reducing serum lipid levels and even reduce the while glucose exclusion and reducing constipation, while fiber intake increases because we are reducing carbohydrate intake. We have to supplement like fibers along with that reduces constipation and even glucose exclusions. And lower glycemic index foods, we have to increase the high fiber intake. Even up to 28 grams of fiber intake per day, generally recommended for pregnant women, even reduces with the constipation issues or while they are reducing carbohydrate meals. Role of physical activity in gestational diabetes, like exercise, these are physical nutritional therapy only. These are physical activity like exercise increases like insulin sensitivity and cardiorespiratory reserve. And exercise in conjunction with generally dietary therapy most improves the blood glucose levels control and may reduce the insulin need or any oral antidiabetic levels in requirement of the reduce the requirement also. And according to ACOG recommendations are at least 30 minutes per day of moderate intensity of exercise for 5 days in a week or minimum 150 minutes in a week recommended in ACOG guidelines. Like simple exercise such as walking every um, 10 to 15 meals after each meal, we have to lead to improve the glycemic control. And these are recommended every like simple exercise like every after meal they have to walk like walking 10 to 15 minutes. Most of the patients this will comes 30 minutes total day of exercise like that walking or even effect of exercise and blood sugar values also apparent after 4 weeks of training. And exercise advised during pregnancy or like some of the pregnancies we have to not recommend it like exercise. Some like abruptio placenta patient they have to require complete bed ridden. We have to avoid in that patient not to recommend any physical activity. They have complete bed ridden. We have to cautious about which of the pregnancies the gynecologists there. We have to ask for these pregnancy we can advise any physical activity or not, because some of the pregnancies not even they have to move with without outside of the bed also. Complete bed restriction read in some of the abruption placenta cases. Exercise involving like mostly like upper trunk, these are don't provoke the uterine contraction. Like brisk walking is the safe during pregnancy. Even cycling or swimming, low impact aerobics also can be done during pregnancy also. In pharmacological therapy, even after like medical nutrition therapy, they have tried for 2 weeks. Still, it is a fasting level more than or equal to 95. Even 2 hours after that, postprandial glucose level more than 120 is not controlled under persons. We have to require oral antidiabetic drugs or insulin therapy. Insulin is the main agent for gestational diabetic patient. They we have to give like that even first trimester also we have to give insulin therapy. Insulin like that these are red when blood glucose target can be reached diet and diet we have to cannot reach by diet we have to advise insulin required. Even like postprandial glucose level more than 140, even HbA1c more than 12.5, these are the patient we have to require insulin directly without like waiting of the medical nutrition therapy or something. We have to directly insulin. We have to first line treatment. We have to start insulin, reduce the glucose, strict glycemic control. We have to uh, produce. And need for like pharmacological therapy more than for even 30 weeks, and fasting glucose level not controlled, and even like postprandial glucose also more than 140. These are the patient, and even who patients weight gain also more than 12 kg. Insulin, because of why is the safety? Because this does not cross the placenta, even can achieve the tight metabolic glycemic control in pregnancy. That's why insulin levels are indicated in patients with a gestational diabetic patient. Insulin requirements also, insulin requirement increases the pregnancy. During pregnancy, insulin requirement varies and follows on, like first trimester. Generally, we have required insulin is at 0.7 units per kg body weight, or and second trimester it will increase 0.8, and third trimester like 0.9 units per kg we have to, because insulin resistance increases maximum 24 to 28 weeks. Maximum insulin resistance increases. The increase require of the insulin levels also increases during, while increasing gestational age time. We have to some of the insulin, mostly there are insulin therapy like premixed insulins available, or like short acting like Lispro, Asparto, and these are the insulin mostly recommended in pregnancy. But long acting insulin like Deltamere and Glargine, these are still under trial, not confirmed. Most of the patients, like mostly short acting and intermediate, like NPH insulin or premixed insulin forms, and short acting insulins only pregnancy indicated. Like most of the tests still long acting insulins are not tried even continuously. There are various other insulin not tried still, mostly like short acting and intermittent insulin only tried GDM patients. In that these are not like large and determine still not safety levels not controlled. That's why mostly we will follow like premixed or short acting insulins only during gestational diabetes patients. We have to give it there. In another like oral hypoglycemic drugs, like uh, we have to select like these are processed placenta, and again any some of the complications. That's why in metformin and sulfonylureas only, like glyburide and glibenclamide only some of the less crossing of the placenta. That too, metformin is a good choice for second and third trimester patient. In some of the 10 to 12 like randomized trial, like metformin is safety. Why? Because of these are reduces the weight gain of the reduces the weight gain and reduces the insulin levels also during while pregnancy progresses. Along with the metformin, we are using insulin, no, reduces the insulin requirement and reduces the pregnancy weight gain also. Like insulin itself causes some of the weight gain. Some along with the metformin, some reduces the weight gain of the patients also, and even birth weight also some reduce the birth weight of the babies, and hypoglycemic events also reduces in uh, along with the metformin. Some of the benefits are showing in metformin, but these are short-term efficacy. Even still needed for metformin, also long-term safety trials or uh, were concluded with without any effects or not now till now. But mostly like short-term, they are mostly effective, showing birth birth weight of the babies reduces, and even weight gain of the mother also. Pregnant mother reduces some of the weight, and insulin requirement also pregnant lady reduces in, along with the metformin insulin adding, no, their dose also requirement also reduces. And these are the increases the peripheral utilization of the glucose levels, or insulin sensitivity also increases. That's why metformin is the safer in pregnancy. Even second and third trimester patient they have given uh, still like glyburide less chances of process placenta, but uh, till now like metformin only tried and tested for second and third trimester GDM patients. These are efficacy showing better chances for even controlling of glucose levels in gestational diabetic patients. Remaining like obstetric management, these are antenatal management, like frequent antenatal visits for every 2 weeks till 32 weeks. Then every week in after 32 weeks, we have to need antenatal checkup, and maternal fetal surveillance done in obstetric. These are obstetric management, like maternal surveillance, like screening of infection, per speculum examination, vaginal any, and urine routine, urinary infections or any glycosuria or any culture and sensitivity we have to done, and close watch for any preeclampsia, any developing patients with, along with the gestational diabetic patients. And fetal anomalies, generally we will 16 to 24 weeks we have to do fetal anomalies, and patient may be advised for daily fetal how many movements are occurring, and fetal fundal height, and these are measured during antenatal visits, and serial ultrasound for fetal growth, fetal weight, any amniotic fluid index every 2 weeks also. 32 weeks onwards, they are mostly NST and they are going to every week. Fetal ultrasound also they will done. And during time of delivery, patient with a GDM on diet, they mostly like antepartum fetal surveillance. We can wait up to like 40 weeks, but mostly elective LSCS or elective deliveries, they are better for patients with gestational diabetes with 38 weeks completed only, better for not to wait further, because even some of the 1 to 2 3% 3% cases like sudden intrauterine death, intrauterine death cases are noted in patients who can they are going to develop preeclampsia, any vascular sugars, vascular diseases they are going to develop. Mode of delivery mostly like elective cesarean therapy. Labor we can done because of macrosomia or cephalopelvic disproportion can be ruled out. Then only we have to for normal labor. But elective cesarean indicate like big baby like microsomic babies they have to indicate, and obstetric indicates like placenta previa, any malpresentation, severe IUGR patients they have to going to uh, do for elective cesarean section. Intrapartum, like uh, elective induction of labor, then night dose of insulin is given, morning dose withheld before induction planned morning. Induction labor done with oxytocin depending on bishops. Their blood glucose monitoring every 2 hours also. They have to maintain blood glucose level less than 140 milligram per DL also. Even sir, they have to glucose infusion with insulin. We have to start and titrate according to the capillary like glucometer checkups, and we have to monitor glucose levels. And even every 4 hours also we have to check urine ketones levels and serum electrolytes every 12th hourly during intrapartum stage while they have induction of labor conditions. How much dose like the sliding scale during insulin titration like 140 to 148 4 units, and 180 to 258 units, and 250 to 12 units more than 400. They have to get 16 units like that. We have to titrate. During labor, they have to monitor the progress and maternal fetal well-being and fetal heart rate and electronic monitoring. These are facilities available condition, and intermittent auscultation every. These are like gynecologists. They will monitor during labor stage, and strict. They are more prone for infection. You have to strict aseptic condition maintain increase. Uh, there are reduces the increasing infection intrapartum stage, and even number of per vaginal examination we have to reduce. And postpartum, like early breastfeeding as early as possible, started babies like to avoid hypoglycemia in babies. Maybe like sometimes we have to require continue prophylactic antibiotic, and insulin requirement will fall immediately after the delivery of the babies. And blood sugar levels should be tested to 24 to 48 hours after the immediate after 24 to 48 hours of the delivery. Most of the women like with the gestational diabetes they have to monitor blood sugar levels every 24 to 48 hours of the delivery. And
Hello. Sorry to disturb you, sir. Sir, I think you are muted. We can't hear you.
okay.
Yes.
Like postpartum management, like early breastfeeding, we have to start avoid hypoglycemia in the babies and continue prophylactic antibiotic, and insulin requirements also falls immediately after delivery. Blood sugar should be tested every 24 to 48 hours of the delivery. Generally, gestational diabetes not require insulin postnatal period, and even most of the patients advise normal diet also. Even after the gestational diabetic patient postpartum, during after 6 weeks after that, we have to follow 75 grams of the oral glucose tolerance test. We have to follow, and then if levels are increases, so levels are increased, they are converted to type 2 diabetes mellitus. If patients with over 2 diabetes, the dose of insulin should be adjusted according to their insulin requirement and maybe changed to oral hypoglycemic agents during postpartum levels. In long-term follow-up patients like that with GDM, they have 50% of the chance of developing gestational diabetes next pregnancy. and there is a 50% of developing core diabetes and later in half of the life. Thank you. But in GDM patient, we have to like in patients generally we have to pre-meal test. 4-day testing is the better for we have some of these seen in like there are fasting and 3 times of post meal we have to checking compared to like 1 hour pre-meal condition like there are chance of compared to HbA1c reduction most followed in better in 1 hour of the post meal compared to like pre-meal checking like HbA1c 12% reduction in post meal like one fasting and 3 of post meal checkup compared to like one fasting 3 meal checking of the per day checking there are more reduction in HbA1c we have seen some of the patients while following up the GDM patients post meal checkup post meal glucose levels monitoring is a good reduction of the HbA1c we have seen some of the patients compared to pre-meal glucose levels monitoring of the patients. Thank you very much.
Thank you so much, sir, for your presentation. We have received a couple of questions which we will take one by one. Um, so, Dr. Robinson has asked how recurrent UTI is related to diabetes.
Uh, because these are glycosuric conditions, they are more prone for urinary all pregnancy. Also, sometimes it is a recurrent urinary tract infection because of GDM. They have glycosuric present. Uh, there are minimum 10 to 20% of chances of their increasing compared to normal pregnancy. They are more prone for urinary tract infection in gestational diabetes compared to like normal pregnancy patients.
Yes, sir. Thank you. Next question, sir. Uh, Dr. Ravindra Kulkarni has asked, is there any role of GLP-1 group of drugs in gestational diabetes?
Still now not available any trials for GLP-1. They are not tried for only still now metformin is going on that too. Short-term safety only trial for metformin. Even like glyburide is a less chance of placenta class, but still now not tried for even glyburide and glibenclamide sulfonylurea. GLP-1, some other drugs still now they are not tested for any GDM, how it is effective or how much it is a safety precautions. Till now not known any trials are not there.
Yes, sir. Thank you so much. Next question is the status of metformin therapy in GDM if the lady is reluctant to accept insulin.
Like I didn't understand. Like status of metformin therapy, it is a good one for because it is a reduces weight gain of the one of the birth of the babies and along with the mother weight gain also reduces because insulin itself is a some of the weight gaining conditions in normal persons also insulin is one of the side effects. But metformin reduces the weight loss and birth baby, neonatal hypoglycemia also reduces chances. Some of the good clinical trials still it is showing like neonatal hypoglycemia reduces the birth weight of the babies, even reduces the weight gain. Total overall pregnancy weight gain also reduces because these are increases the insulin sensitivity also. That's the increasing the level of along with the metformin insulin therapy. We have to reduce the insulin levels also. Requirement of the insulin controlling the glycemic control also requirement also. Dose reduction is happening along with the metformin therapy compared to plain insulin we have tried or anything.
Yes, sir. Sir, Dr. Dinesh has asked the role of HbA1c in gestational diabetes mellitus.
We haven't seen like we have to like GDM two types are generally over diabetes are it is a gestational diabetes means if we are HbA1c more than 6.5 or more than 9 it is coming there HbA1c no it is already over diabetes patient unaware of the GDM while during antenatal first antenatal we have done HbA1c now if showing more than 6.5 or 9 is there anything these are over diabetic patient not a during pregnancy develop or sometimes we have to like first 6 weeks or 7 weeks of they are coming there. We have to it is a over diabetes or how to diagnose it is a gestational diabetes. HbA also some of the role is we can identify it is a over diabetes or GDM also it will divide pre-gestational diabetes or gestational diabetes also.
Yes, sir. Thank you. So the next question is, why is long-acting insulin not used or not preferred in gestational diabetes?
Some still it is like mostly there are insulin like short acting lispro is the role is there. Some of the insulin and intermediate acting like NPH is there. They have most of the trials they are used for insulin as the main therapy. Long acting like glargine are not safety efficacy or till not exactly because of they are fasting hypoglycemia. Like in diabetics, gestational diabetes is a mother they are going to develop fasting hypoglycemia. Maybe till now not they have tried, but some theories like that because of fasting hypoglycemia mother itself and postprandial hyperglycemia state. If you are long acting insulin, no, it is a mostly control like fasting levels, no, further lowering of glucose worsen the hypoglycemic condition. That's why I till now no conclusion is not, but not tried. Most of the trials only short acting and intermediate acting only they have tried for GDM gestational diabetic patient.
Thank you. Uh, like PIH can continue even after childbirth. Is gestational diabetes can does the gestational diabetes also continue after delivery? And that you can you please repeat the points that you mentioned for the postpartum phase?
Like GDM, no, we have to like most of the times, even immediately after delivery, within 24 hours, they have requirement of the insulin mostly reduces or maybe not require also insulin they will have. Or some of the over diabetics patient, they will require as per the glucose like capillary glucose monitoring like glucometer we have checking, no, they have require insulin. But if GDM patient not requiring insulin, no, still we have to follow up after 6 weeks with 75 grams of oral glucose tolerance we have to do. If there are anything showing more than 140 or anything more than 200, we have to further work up for it is a over diabetes is there. We have to see there. If not there, mostly it's a recovery of not require any insulin therapy or no nutrition therapy also.
Yes, sir.
6 weeks requiring.
Thank you, sir. So the next question is there any difference in the primipara and multipara in diabetes treatment?
Not such difference is there, primipara or multipara, but multipara means what happened. No, we have to early diagnosis or some of the patients we have to need counseling because they will come like first antenatal also we will cautious or we will do for in multipara patients already over diabetes means no some congenital anomalies or abortions we have to expect. In primipara or like GDM means less chances of congenital anomalies or abortion. That's the only difference, but nothing much treatment as well, no difference. Only like fetal complications we have to expect or baby weight or anything or anomalies we have to see only. It is a over diabetes or the GDM only there is a, but treatment was same only. Nothing as much change will change.
Yes, thank you. The next question is by Dr. Jitendra. The preferred oral hypoglycemic agent in lactating mother to avoid hypoglycemia in the infant as well. When switched from OHA to insulin after delivery.
Metformin is a better choice for oral hypoglycemic agent. In some of the like glibenclamide or sulfonylureas, you can try it there because once you can after placenta delivery, there is no need for any contraindication. Some of the like GLP-1 they are not given, but metformin is the most of the patients with after the GDM. Uh, Metformin one or two drugs only requirement of the controlling other than the insulin.
Okay, yes, sir. So just continuing with the same question, what is the maximum dose of metformin recommended in pregnancy?
General recommendation is metformin like uh, 4 grams, but like 2 grams after that, most of the patient will not tolerate. Like gastritic issue, pregnancy itself is the gastritis will develop and bloating and abdominal discomfort. They have to not to take proper like gastritis and the diarrhea. These are the metformin itself. Even normal persons also develop. So mostly like once you can go into more than 1.5 gram, we have to better to switch to along with that insulin is a better choice because tolerability decreases during pregnancy. Metformin, if you are going to 2 grams, more than 2 grams, even still 2 grams also very difficult to patient will continue uh, the daily intake of metformin because of gastritis and diarrhea and some of the bloating or abdominal discomfort issues develop.
Yes, sir. Thank you, sir. Sir, we have a couple of more questions. We'll take them up one by one. Uh, Dr. Rajendra has asked, can you please repeat or describe the method of diagnosing, the one-step method of diagnosing GDM?
One step method is like DIPSI guidelines are there. Like in India, government of India adapted like recommendation by DIPSI, like diabetes in pregnancy study group of India. This is what will tell, like far irrespective of the fasting, they will come from far from hospital. We have to like wait for fasting, not required. We have to without fasting, we have to give 75 grams of the oral glucose with 200 ml of water, mix it, and yeah, they have to take within 10 to 15 minutes. After that, 2 hours after that, we have to check postprandial levels. If more than 140, it is a gestational diabetes. uh, in this one step method, what is the advantage? They have not require any fasting or some of the like overnight fasting, or they coming from any what time they are coming there, like afternoon, 11 o'clock, 12. They're not required. We have to go in directly 75 grams of oral glucose we have to give, and we have to test after postprandial glucose levels. If more than 140 it is come, we have to directly diagnose as a gestational diabetes levels.
Sir, thank you so much. Sir, how do we do monitoring of the blood glucose in case of a gestational diabetes patient?
In gestational diabetic patient like that, second trimester, we have to generally follow up like 2 weeks follow up of the fasting and postprandial levels. But in third trimester, we have to better to follow every week. It is a good for state glycemic control. Every week we have to follow fasting blood glucose levels and postprandial blood glucose we have to follow and maintain less than 90 and postprandial less than 120 is a better glycemic control.
Okay, sir. Just 1 minute. This is the one last question, sir. Can macrosomia be managed with oral antidiabetics?
Like I think macrosomia not related to our treatment. Macrosomia is still complication of gestational diabetes. Metformin is a better choice you can manage with their mother glycemic control. We have to strict monitor. If we are better management with oral like hypoglycemic agents like metformin, you have to giving their glycemic controls are fasting and postprandial levels are within the range. You have to continue till birth. Before going to delivery, we have to switch over like insulin drip or whatever it is. But macrosomia, it is a complication of GDM. I think you can give it the oral antidiabetic drugs like metformin can give it the even macrosomia baby also.
Okay. I think if there are any more questions, please mention them in the comment section on the right hand side panel. In the meantime, sir, if you have any takeaways or any to dos that we should remember while in our day to day OPD practice regarding gestational diabetes.
Day to day practice means like we have to like any pregnant patient with obese or like any married couples or they are planning for pregnancy anything we have to encourage the patient obese persons we have to reduce the weight at least 3 months prior or any previous illnesses of like abortions or any stillbirth we have to supplements like the folic acid. These are the recommended for babies for reduces any anomalies, and we have to requirement of they are going to gestational diabetes also before pregnancy we have to reduce the weight, no, some of the they are in their pregnancy also weight gain is the occurs. That's why we have to before pregnancy we have to advise patient for appropriate BMI maintain, and any previous illness is the proper supplements we have to advise before conception only is the better advice for 3 months before they have to go for any planning of pregnancy. It is a take away better, even avoidable, or at least we have to late gestational age requirement of the insulin or metformin, low doses requirement will be developed in their pregnancy gestational age.
Okay, sir. Thank you so much, sir. I think that brings us to the end of our session and the Q&A talk as well. Thank you so much.